can we get both speakers up here? I think we have lots of things to discuss. I think it's great because what we essentially need to discuss now is that we need a more holistic management of our patients, which what Jean-Louis hinted at starts with screening, phenotyping, but then goes to not just addressing the night or the day, NIV or oxygen, but having a complete solution for the patient that can then be monitored. And after all, we just need to manage more than devices. We need to manage the head of the patient, which is in between, because he can have all the devices in the world. If he doesn't use them, we don't make him better. So lots of things to discuss. Please come to the microphone, introduce yourself.
Thank you. Well, I'm from Bulgaria. My name is Peter Chipev. I wanted to ask Jean-Paul for the monitoring part. Most of bi-level devices have incorporated mechanisms to measure tidal volume and minute ventilation. Do you monitor this part of the report that the device can tell us? Do you think it's precise? Because when we use very high pressures in most patients, the device calculates tidal volumes more than 1,000 or stuff like that. Is it real? Can we monitor this parameter?
Yeah, I think it's really interesting. You have, if you look at the raw data in the different brands, now you have like a respiratory polygraphy. And if you are a little bit experienced, you can, I don't care about the value of the tidal volume, but if you look at the different patterns, you can easily identify leaks, persistent upper airway occlusion, asynchronous. So you have very interesting information on the mechanism for persistent residual events. And if you can combine with transcutaneous PCO2 and SiO2, you have enough information. And I think I was a co-author of the Somno and IV paper in thorax, but I think the true indication for full polysomnography in the follow-up of this patient is less than 5 to 10%. You have really a lot of interesting information. The only limitation is you have only raw data from several nights, a limited number of nights. So you have to check in your action group that this patient has a problem and ask to have the raw data of the previous nights.
Thank you.
Any more questions at this moment? I have a question to Klaus. My point is, if we start NIV, and we talk about this issue a lot this evening, do you think it should be always part of a rehab program? So not to only to start up NIV, to do the follow-up, but should be part of the rehab program, so put more attention on different, from an angle to the patient?
Yeah, the answer is yes, but there are several things one has to discuss with that. Rehabilitation is a broad spectrum of offers. And as I tried to show, if you do it very properly in a comprehensive way on a high level of knowledge, you can achieve a lot of incredible things. But this is not true for the entire spectrum of rehabilitation. They are mostly not really accustomed to that or experienced with that. So you have to see what kind of rehabilitation. The first question is, should they go to rehabilitation? And also I would say definitely yes, because if they have survived this critical situation, if they are adapted to perform this, and if they are compliant, they will live longer. That data show. But I think we have to get them out of the bed, out of the wheelchair, out of their chair, and to get them back to active life. Mm-hmm. And my future perspective would be, and a friend of mine is already working a little bit on this, to create once a machine that is able to measure activity, to see what's happening to CO2, to oxygen saturation, adapt non-invasive ventilation while walking, and so on. And so I think that really brings then people and patients back to their not normal life, but at least to be part of normal life. And another aspect, as the recent studies have shown, that the decision, does a patient really need non-invasive ventilation on a long-term base, sometimes is only to be answered after some weeks. And at that time, the patient is out of the hospital. And if then the patient would be at the setting, and we see that very often that we can stop non-invasive ventilation because we measure them at nighttime with the Zentec, and they have CO2 levels of 36, and so we stop it and control it, and if they keep stable, then you can say, okay, there's no further need for that. And so I think there are several positive roles rehabilitation can play in this field.
There is a paper in press in ERG showing 3 different groups, one usual care, one rehabilitation for 2 months, and one maintaining a rehabilitation by using tele-rehabilitation systems. And there was, it's a randomized controlled trial, 120 patients, I think. The effect on reduction in hospitalization exacerbation was really huge. Yeah. So yes, I think it's really interesting.
Professor Pépin, you showed us this slide with problems that may arise during NIV, such as leak or unstable upper airway, asynchrony, etc., persistent hyperventilation. Now, as you know better than I do, that these problems may be interrelated. Leak could lead to upper airway instability or could lead to asynchrony, etc. And on the other hand, leak may be without any meaning. If the patient doesn't suffer and there's no asynchrony, etc., it might not matter at all. And solving these problems may be complex sometimes. Like you may raise, if there's no leak and you have upper airway instability, you may raise EPAP to resolve upper airway instability, but you might end up with producing more leak or something like that. So you had as one of the options for exceptional patients polysomnography, which may be required. Would you agree that actually not only polysomnography but supervised polysomnography with manual titration may be helpful in such cases?
I am not sure that I am going to support this. It looks like too complex for the management of these patients. First of all, you are right. Some of the unintentional leaks, if you have no symptoms, no oxygen desaturation, no sleepiness, sometimes you don't care. And again, if you have very simple tools, and I think transcutaneous PCO2 at home is really interesting. You have the raw data. You can see on the raw data of the devices, you have a big breath when you have a microaerosol. You can see the obstruction of the upper airway. The most difficult situation is to separate glottis closure versus obstruction at the pharyngeal level, but you are going to solve the large majority of the problems you have. And another very important clinical message, don't use too much orofacial mask or facial mask in this situation to correct leaks that actually do not have any consequence.
Yeah. Because also you might end up producing more obstruction with oronasal masks.
Right.
Let us take the discussion to 2 more, I think, important points of the symposium. One is what you presented, Jean-Louis, which we need to discuss, looking at data rather longitudinally than taking clinical decision on one appointment, which we normally do. I mean, we see our patients 10 days a year, and we think we can influence with that 355 others. I think that's one topic. The other topic I would like to start a discussion on is, Klaus, you showed a very nice study about oxygen. I mean, we use oxygen quite bluntly in clinical practice. Nobody really looks after it. You write a prescription, it's 2 liters for Christmas, for New Year's Eve. It doesn't matter if you're on your treadmill or if you're having a birthday party. And what we saw is, of course, those 2 liters makes it better, but there's still significant hypoxemia and different phenotypes. So I think something we need to have a discussion on is, how do we do that better? Because that trial shows an improvement, but actually the quality, if we would compare it to an NIV setup, that is reducing your CO2 from 7 to 6.9. Yeah, so it's amazing that we already get an improvement, which shows the potential of what we can do with oxygen if we do it properly and if we do it continuously. So I would like to get the experts' thoughts on, what can we do? What do we need to do? What do we give the clinicians home? What do we do with oxygen? What can we do better?
Yeah, good point. What we see is that most patients come with, let's say, 2 liters, one size fits all.
Yep.
It's at nighttime, at rest, during exercise.
Yep.
And that can't work. And what we usually do is to look for these 3 conditions: rest, nighttime, and exercise condition, and see how much oxygen the patient needs, and may end up with 1 liter at rest, 2 liter at nighttime, and 5 liters at exercise. Okay. And then I think long-term oxygen therapy can really show its benefits, and not with this strict. And this also was a limitation for the data I showed, that we had set this 2 liters fixed, and I'm sure that was not clinically correct, but that was a study protocol. Yeah. And when you adapt that individually, I think that's much better. And what we also look, and what I think is also not really seen, that the influence of oxygen therapy on CO2 levels is not really observed or looked for. And we do that, and fortunately, it doesn't happen so often that it really increases. Sometimes it's stable, sometimes it's even going down. And I think these are things we will study in further trials. And so I think we have to learn a lot about this, and we have to perform oxygen therapy much more individually tailored than we did it until now.
Yes, I fully agree. I think we need obviously a titration for oxygen therapy. There are some old studies showing that at least 50% of the patient with a single prescription of oxygen therapy are desaturating during the night and during exercise. We also need some technical advance, and we did present in the ATS, and the paper is now submitted. There are some now automatically adjusted system for oxygen therapy, measuring the SO2 as you allude, and during exercise you have an adjustment. And as clinician, we are hesitating to increase a lot, especially in hypercapnic patient. And what we shown was, even in hypercapnic patient during exercise, you can increase a lot oxygen therapy without any deleterious consequences. So yes, we have to implement new modes for titration and follow-up of oxygen therapy.
And I think to add to that then, because I love what you said about activity, because I think that's our major problem in COPD patients. I think activity is the better drug for the lungs than dual bronchodilation. But then we need solutions that they can apply it. Because if you give a 75-year-old a 2-liter cylinder, which needs 3 grandchildren to carry it, I think that makes it also difficult to support daily activity. So I think there's an unmet need, I think, that we have to address. Going to this other topic, before we close down here, I want to discuss that because I think that's really changing the landscape of medicine. You had your virtual clinic, the picture that I really like, but I think the key point of this virtual clinic, and also that's a little bit the advantage that you have in your setup compared to my setup where I see a patient on a daily visit, that you get more information, that you're able to tailor treatments differently than on a single. It was yesterday a very interesting presentation about smart hailers, where a patient was discharged after an exacerbation, and she used her, we can say it's not pharmaceutically sponsored, we can say it was a Viani discus, and she used it the day she was discharged. She showed it to the nurse that she can do it, and she used it the day she saw her pulmonary doctor again, so she used it twice. When you would ask her in clinic, you would ask her, did you use your haler? And she would say, yes, I did. Did you use it regularly? Yes, I did. So what you do, you would change your therapy. That's what you would do. Yeah. The other patient was cleverer. She just did the day before she came to the clinic with her Viani discus 60 times this, so the discus was empty. Yeah, she threw out the powder, and she said, well, I used the whole thing, brought it back. So I think here is an opportunity for us that you have currently in rehab with your special setup, but I want to get your thoughts. You started a discussion with the studies you presented where you look longitudinally at data which you can have from oxygen, which we can have from ventilators, which we might have from other sensors in the future. What's the role of that in the future?
Yeah, before addressing your question, I would like to insist for the respiratory physician in the audience, the decline in physical activity is more important than the decline in FEV1.
Yeah.
So it's important to put this in clinical practice and then to measure physical activity. I think the true challenge is to change, as you said, the behaviors, and it's really difficult. Monitoring is not enough. Mm-hmm. And for example, there is in the field of sleep apnea a nice study in press in the Blue Journal, the Tele-OSA study, mm-hmm. showing if you send text messaging to the patient, mm-hmm. immediately after interruption of text messaging, you have a decrease in adherence. So we need some innovative mode of coaching, as you said. You need more self-management plans, some patients' community to have a discussion between patients. So we have to invent a new long-term care and to involve people able to provide some resources for learning, for engagement, for it's not only monitoring.
What I think is that's the most important point is to change behavior. But if you look backward, let's say 10 or 20 years, I think we didn't succeed in changing it. Mm.
Yeah,
I think
so
that's the big problem we have. And I think the patients, we all talk about NIV and oxygen and medication, but in the end, when a patient will stop his or her rehab program, he will fall back to the old situation. I think that's the main, in my view, one of the main problems.
So we need to use medical devices to augment change of behavior. On the other hand, we can, because with a ventilator, the patient can walk longer. So we just need to get that all under one umbrella in the future, more holistic management.
But when we expect patients to change their behavior, we also have to take in consideration that in their minds, there's a lot of anxiety, tendency to panic in terms of oxygen therapy, shame. And if we don't address these things, we can't expect the patient to do that in their everyday life. We would call that non-compliance, but I think that's not non-compliance, but they can't jump above these hurdles. And I think anxiety, especially in non-invasive ventilation patients, plays a tremendous negative role. And I think we also have, beside of working with the non-invasive ventilation machines, also on these issues in order to make that for the patient acceptable, or even to show that really with losing or decreasing the anxiety levels, quality of life with that also may increase.
And Nick is back. And
well, but it's 7 o'clock, Nick. You can get one closing remark.
I just want to say as well, we've got to look at cognitive function. Yeah. We can't miss out on what the patients are in terms of cognitive. Using non-invasive ventilation is the best treatment for dementia, it turns out. So we did some Montreal cognitive assessments on our patients pre and post non-invasive ventilation. They get brighter. Yeah. They get brighter with NIV. That's not surprising because they're not bathed in CO2. But
are you using it?
Am I using it?
Yep.
Yeah, every night.
Is the pressure high enough?
High pressure, not high intensity.
Well, let me say two things. It's 7 o'clock and we need to wrap up. First of all, we want to thank ResMed for putting together this innovative session to give us a forum to discuss these things which go beyond currently available technologies and to highlight, I think, unmet needs. That's one thing, so thank you very much for that. Number two, I need to thank my co-chairs because my luggage got lost. I didn't have a tie, so they all took their ties off. So thank you very much. I think you still look very elegant. And number three, we want to thank you for joining us this evening at that late stage. We wish you a great evening in Milan and a good rest of the year. Thank you very much.
Thank you very much.